Hi, thanks for joining us today for episode number 105 of the Doctor Podcast Show. And I'm your host, as usual, Dr. Robert Cykiert. We'd really appreciate if you could subscribe, follow, like, repost, and share this episode so we can get other great guests on the show like we have today. And our guest today is Dr. Ula Yurkunis. Dr. Yurkunis is a distinguished ophthalmologist and clinician scientist at Mass Eye and Ear, and she's a professor of ophthalmology at Harvard Medical School, which is one of the top ophthalmology programs in the world. She's renowned for her innovative work in corneal and external disease and also ocular surface diseases. She's a leader in stem cell therapy. Stem cell therapy is a very hot topic these days. It's affecting many organs in the body. There's a lot of research being done. And Dr. Yurkunis is one of the world's top researchers in stem cell treatments for various eye diseases. And she's developed something called Limbal stem cell deficiency treatment, which we'll talk about. And she has spearheaded the first xenobiotic-free, serum-free, and antibiotic-free protocol for cultivated autologous limbal epithelial cells, or KLEC. We're going to abbreviate that. And that's a transplantation technique used for people with corneal diseases that have limbal stem cell deficiencies. She's done a groundbreaking clinical trial, her recent phase 1/2 clinical trial, which was published in Nature Communications, one of the top journals in the world. And she demonstrated the safety and feasibility of limbal stem cell transplantation, or KLEC transplants, which was funded by the NIH. She's also committed to training the next generation of ophthalmologists and advocating for accessible, cutting-edge treatments for vision impairment. So I would really like to thank you, Ula, for taking the time from your busy, hectic, I'm sure crazy schedule to join us today to talk about your research. Really appreciate it.
Thank you very much for having me. It's my great pleasure.
Thanks. So tell us about what inspired you, first of all, to go into ophthalmology and then to become a cornea specialist and then become one of the top researchers in stem cell research for treating various corneal diseases.
Well, thank you for that question. I think that I was always interested in something surgical, to be a surgeon, and I wanted to be a focused specialist, something that I can know really well and be kind of one of the main people who understands the mechanisms of how things are causing the disease. And it seemed like ophthalmology was a great mix of medicine and surgery. We ophthalmologists do a lot of surgeries, but at the same time, we are dealing with a very small, fragile structure of the eye, and we are able to be very focused into the eye structure. So furthermore, cornea is the clear outer layer, and I think that it's one of the most beautiful parts of the body because it allows us to see, and it allows us to see because it has a very specialized structure. The cells are all have a purpose there. And I think that throughout my training and throughout my career, I always wanted to continue to improve upon that clarity of the cornea.
Right. The cornea is the window to the soul, right?
That's right. And we see through the cornea inside of the eye, and we can actually see into almost the brain because we can see the optic nerve directly through the cornea.
Is very important. Now, tell us about your path to Harvard. You're a professor at Harvard now, which is extremely prestigious, and congratulations on that. And you're also a clinician at the Mass Eye and Ear Infirmary, which is affiliated with Harvard. What were some of your pivotal moments and some of your mentors in your career who shaped your path to become a leader in your field?
Well, I think that my career path started early on with inspiration from my family. I think the family was really important in supporting my passion for medicine. My mother supported my immigration to United States from Lithuania. She spearheaded us moving across the world and has been by my side throughout all my career path. So it was wonderful to move to United States and to start medical school. I started in University of Louisville in Kentucky, and then moved to Boston for residency at Boston University, Boston Medical Center. And over there, I felt like I had so many wonderful clinicians who inspired me to be a very prolific surgeon. One of the inspirations was Susanna Rowe, who directs the faculty development, and she has been a great mentor and friend. And she really literally took me by the hand and walked me over to Mass Pioneer, where she used to train. And this is how I became a fellow at Mass Pioneer for cornea and external disease. And in Mass Pioneer, I met multiple wonderful faculty who were surgeons, but they were also researchers. And they always wanted to go beyond just helping one patient, but trying to help many others with the new discoveries. And that really inspired me to pursue the clinician scientist career.
That's a great accomplishment. And Mass Pioneer and Harvard has some of the most brilliant ophthalmologists on the planet. So you have a lot of mentors there. Now, you wear lots of hats. You're a clinician, a surgeon, a researcher, educator. You're training ophthalmology residents. How do you manage all these different things, and what strategies do you use to stay focused and effective in each of those?
I think they seem, initially like a little bit different things that maybe pulling you apart into different directions. But in reality, all these hats help you achieve one common goal. And that is, improving patient care and forwarding the research. Because without teaching others, you are not able to really accomplish the scientific undertakings. We teach fellows in the lab all the time. We teach fellows in the clinics and surgery. And all these individuals have been the main contributors to the success of our research. So I think being in a team is one of the critical things that allows you to succeed.
Right. Now, tell us some more in detail about LSCD, or limbal stem cell deficiency. What is that, and how does it affect people's vision and lives?
So limbal stem cell deficiency is a disorder of peripheral corneal stem cells. So as adults, we do have stem cells, even though they're not embryonic anymore. They're called adult stem cells. And in the cornea, they reside in the periphery. And they really are the reasons why we have this beautiful, clear, and transparent cornea, because they provide the source of surface epithelial cells. They're like skin cells, except they're transparent. And there are multiple diseases in your body that can affect those stem cells and destroy them. Some are immunological conditions, genetic disorders, and it could also be trauma, chemical burns, thermal burns. And when, for example, a chemical injury affects the cornea, that's the first thing that it destroys is those stem cells. And therefore, we get stem cell deficiency, which leads to opaque cornea. Also, cornea develops blood vessels at that time, and it shouldn't. Blood vessels usually do not grow in the cornea. And people lose vision and they have pain. So all these things lead to limbal stem cell deficiency.
So instead of the cornea being crystal clear and transparent, it becomes cloudy, almost like looking through a frosted glass window pane instead of a clear window.
Absolutely.
Right? So tell us about your research with KLEC and your publication in Nature Communications recently, one of the most prestigious medical journals on the planet. And tell us about your xenobiotic-free, serum-free, and antibiotic-free protocol for doing these limbal stem cell transplants. What inspired you to take this approach, and why is eliminating these components that I discussed, those three components so important in getting successful transplants?
So even though we're now in 2025, this research actually started in 2006, believe it or not. And it takes a long time to develop a novel therapy. It started when I became a junior faculty member at Mass Pioneer, and I was approached by my supervisor of a cornea service, Reza Dana, who said, well, there are some therapies that are emerging in the world to replace these stem cells, but none of those therapies are available in the United States. So therefore, I was sent to Japan, Kyoto, Japan, to learn some of the techniques that they were using to grow those stem cells in the laboratory and replace the patient's corneas. And after extensive study there, I came back and we shortly realized that the techniques can be definitely improved. For example, the stem cells that were cultivated elsewhere in the world were grown with animal-derived products. So, for example, mouse embryonic fibroblasts, little cells from the mouse embryos, were used to co-culture the stem cells to help them become more stem-like in the laboratory. There were also other ingredients that were used. And we decided to improve upon that and to develop a process that would be in some ways cleaner, less risk of rejection by human body, and also compatible with FDA requirements, which are fairly stringent here in the United States. And as a result, I set on this goal to develop this with a team of researchers from Children's Hospital, Miriam Armand, from Dana-Farber Cancer Institute, Jeremy Ritz. We developed a team and we received grant funding from National Institutes of Health and National Eye Institute, NEI, to develop this technology. And it went through many stages, but eventually it was developed as a product deemed suitable for human transplantation. And we started our first patient in 2018.
A long process, took many years.
Took many, many years to develop. We had to actually test every ingredient we use to grow these cells to make sure that it is clean, that is not toxic, and it actually works because there's a lot of trial and error to determine what is the best secret sauce, so to speak, to grow the stem cells.
Now, xenobiotic free means there are no components from other animals. It's all human derived. So there's less risk of rejection or transferring strange viruses or things like that. Is that right?
That is very correct. And that is exactly the goal of our technology, is to develop that with no foreign animal materials. We
What
also
about,
developed
yeah, go ahead.
We also developed a two-step process. So we grow the cells in the first stage. First culture is done, and then we evaluate those cells for stemness and their quality. And then we take a portion of those cells and then grow them on the final product, which is on the amniotic membranes. They are membranes that are commonly used in eye surgery. And then that product, that final product, is then placed on the eye. The technique was developed such as that we cannot really biopsy or sample the final product for quality testing. So we used two steps, and the first step is used to do all the quality and stemness evaluations.
Now, what does the serum-free component mean? Why is that important?
So a lot of those cells, like the epithelial stem cells, they like cow serum. It's also an animal derived product that can be used to grow the cells. And we remove that portion of the culture because that also would mean that there are animal derived products in the calic.
And why is antibiotic-free important?
Well, because if you're really doing everything in a sterile environment, you don't have to use antibiotics. And having great culture success, meaning feasibility to grow these cells without contamination, is a testament to the sterility of the product. Additionally, antibiotics, just like they kill bacteria and they're harmful to microbes, they actually can harm the cells. So cells are healthier if there are no antibiotics used.
So now you get this layer of stem cells, and how do you transport it from the laboratory onto the surface of a patient's cornea or eye?
So they're grown, the cells are grown in a called GMP laboratory. The lab that we used was in Dana-Farber Cancer Institute. It's a special laboratory accredited for gene and cell therapy for human use. And we also developed this specific container. The culture plates with a calic were placed in that container, and it had kind of like double walls. And it also had no tilt technology, so we could tell if anything is tilted anytime throughout the transportation to Mass Eye Near. It also has temperature regulation, humidity regulation that we can monitor throughout the path to the surgery.
Extensive details, very important. Now, once you take the stem cells, you put them on the surface of the cornea. How do you make sure they stay attached and don't get rubbed off when the patient blinks or touches their eye?
That's right. So we have to actually, first of all, clean the scar tissue. A lot of times people who have stem cell deficiency have developed a lot of scars, and that is necessary to remove that extensively and to treat the blood vessels and to treat the bleeding, which these eyes can bleed quite a bit. And after everything is clean, we're placing the stem cell sheet, the whole sheet on the eye. So the cornea is about 12 millimeters, but we place a stem cell sheet of about 17 millimeters, so drapes even more than the cornea. And in the periphery of that corneal draping, so to speak, we suture that with very thin sutures. They're 10-0 nylon. They're actually thinner than hair. And we stitch them with about 6 or 8 stitches so it doesn't come off. And then after that, we place a large contact lens. So it's not a lens that you would use routinely at home, but it's something that's a medical contact lens. And that is used to kind of shield the drying out of those stem cells and also from protect us from blinking of the eyelid.
That's incredible. How thick is the stem cell sheet that you're actually transplanting?
Oh, it's very thin. It's about probably 10, 20 microns. It's very
Oh,
thin. It's visible from the microscope, yes.
right. Without a microscope, you can't see it. That's incredible. That's where your surgical skills and experience come into play. You have to know how to now attach this sheet of very delicate stem cells to the cornea and make sure not to injure them when doing this delicate surgery.
I think so. I think that definitely this trial was a nice confluence of basic research and that I do, and also clinical work and surgical skill. However, I am very confident that most cornea surgeons will be able to perform this procedure once it becomes more available.
Right. Now, tell us about the adenosine triphosphate correlation. You found this in the intracellular adenosine triphosphate levels and the colony forming efficiency of the stem cells. How did that discovery come about, and how is that important? How does it impact stem cell therapies?
So one of the major areas of research in stem cell field is potency assays. In order to show that a stem cell works, we need to have a potency assay. And this is something that regulatory agencies really like to have, but also it's very important when making the product more mainstream. And because we really cannot take the biopsies of these cells that we already created for patient use, we had to find somewhat of a surrogate assay that would tell us that there are good stem cells, that there's good tissue to transplant to a human. And this is where that first stage of cultivation takes place. We develop a cell sheet first that is not yet going to be transplanted. And we take a portion of those cells and we measure their IATP levels, which is what that assay is. And we correlated the levels of that compound to the colony forming efficiency, which is another method to assess stemness of epithelium. That colony forming efficiency assay is rather cumbersome. It takes a long time and it's not as mainstream, but the correlation was very positive, meaning that most likely we can use IATP assay for the next set of clinical trials to assess the potency of the stem cells. And that has not been done in corneal stem cell field or eye stem cell field.
So you've basically established a benchmark that you can use to judge how good these cells are and how active they'll be on the patient's eye.
Yes, we think that, definitely need more patience to assess, how accurate this benchmark is, but this is a very good beginning.
Now, how long does the bandage contact lens that protects the stem cells have to stay in there? How long does it take for the sheet of stem cells to attach firmly to the cornea so you can remove the contact lens and then eventually remove the stitches?
That's correct. So usually takes about a month because in a month we can remove the stitches, and then that means that the cells kind of with a membrane kind of engrafted and became part of the cornea. So now we're not as concerned for them to be sloughed off. So usually when we take off the stitches, we remove the bandage contact lens. In some patients, we had to keep the contact lens for a longer time, but in some we were able to remove within a month or two.
Now, why aren't these stem cells being rejected by the patient's body?
Well, that's a really good question. This is because we take them from a healthy eye. So this particular therapy is for unilateral cases. So people who have really abnormal corneal stem cells in one eye, but have healthy reserve of stem cells in the other. So therefore, we can use this. It's called autologous product. That means it's from patient's own body. So because it doesn't have anything from another person, it doesn't have any animal products that are potentially toxic. Therefore, there's really minimal risk of rejection.
So the body recognizes it as its own cell and is happy to have it back. Now, eventually, these cells cause the cornea to clear up. So now instead of this frosted glass window, the cornea clears and becomes more like a clear window pane. How long does that take?
So the ability to clear up the cornea completely really depends on the extent of injury and extent of kind of pathology that caused the stem cell deficiency in the first place. For example, we had a couple patients who had a very superficial injury, and they were able to regain completely full vision after removing the scar tissue and placing the stem cells. So that meant that, they have full recovery. However, some people who had really severe chemical injuries had deeper damage, corneal stroma, and other layers of their eye were injured. So replacing the stem cells definitely improved the stability of the cornea, but it did not necessarily by itself clear up the whole cornea. And in some people, we had to actually do a standard corneal transplant after the stem cell therapy because now there was a stable, what we call ocular surface bed, meaning that there's a way for the regular transplant to take because the patient has their own stem cells.
So that helps the corneal transplant recover and stay healthy.
Yes.
That's amazing. Now, what about if a patient has bilateral or both eyes affected, let's say by a severe chemical injury? Would you be able to take their skin, create stem cells from that, and then convert those skin stem cells into stem cells that you could apply to the cornea? Because that would help people who both eyes are abnormal.
Yeah, so the problem of bilateral limbal stem cell deficiency is very important because actually there are many more patients who have injuries to both eyes or have kind of intrinsic immunological disorders or genetic disorders that affected both eyes. So it is our next biggest goal to develop a therapy for these patients, for people who don't have any reserve of their own stem cells in one of the eyes. Now, how do you do that? Well, there are many different ways. Some people actually take, there's some studies showing that you can take it from their mouth, because cornea and the eye is a wet mucosa. So it's best probably to take other wet mucosal cells to generate the cells that are similar to cornea. So that is one way. The other way is to actually take stem cells from cadaveric donors. That would be from corneal peripheries that we get for corneal transplants. Those cells could also very likely can be cultivated in a very similar way of how we established it for these autologous product. The only difference is that these cells will be now allogeneic, so they will be more likely to be rejected because they would come from another person. We
Right.
do think that taking cells that are stem cells but are more already committed to cornea is probably better than maybe taking a cell that is completely not corneal yet and then making it into a cornea.
Right. So the mucosa from the inner lip or the cheek area of the mouth might be suitable for transforming it into a cornea stem cell or similar to a cornea stem cell.
It might be suitable, and there are studies on that elsewhere and again in Japan, but we have not done those studies here.
Another 5 or 10 years of work, it sounds like. Now,
Very
how many patients have you treated with your new technique and procedure? And can you share an example of a patient and a story and how they benefited from it?
We treated in our trial of 14 patients, and we feel like that's a really robust number considering the trial kind of was hit by a pandemic and we had a little bit of slower enrollment. Also, when we started this trial, we had to stagger the treatments, so we couldn't do all the patients at the same time. But 14 patients were treated. At 18 months, we had about 92% success rate, which
Wow.
was really, really good,
Yeah.
considering that this is a first trial of this kind. And also, about 70% of people improved their vision, which was a bonus. We did not power the trial to improve the vision because we understand that vision may not be affected by stem cells directly, but we had quite a few people improve their vision.
That's awesome. So, what next steps do you have to do? What other clinical trials you have to do to get approval from the FDA for this procedure? And so that other doctors, ophthalmologists around the country, cornea specialists can do this.
Well, I think that this is a really good first step, but as you say, we still don't have this therapy available for patients who walk into our clinics. And the next step would be to engage with FDA and to do another trial. Our initial conversations led to the fact that we probably need a phase 3 trial where the patients would be randomized to a stem cell therapy versus a standard of care, which is not very good right now, and therefore randomization was a little bit difficult to achieve in this initial trial. But I think bottom line, we need a bigger trial. We need a trial potentially involving multiple centers, sending the cells to further than Boston, but to other sites, and definitely enrolling more patients.
You think this is scalable? So eventually you can do this on many patients? And is it also a technique and procedure that you can train other corneal surgeons around the country and that can actually grow the stem cells in their lab?
I think that definitely the surgical component is very scalable, and I think a lot of my colleagues would be very, very well equipped to perform this procedure. I think manufacturing is a little bit more challenging because, we did go through quite a tedious process of how to develop this two-step culture protocol and all the assays that were developed to make sure that stem cells are healthy and alive. But I think that, maybe couple centers in the United States could take on this responsibility, maybe something in West Coast and East Coast, and then disseminate those grafts in the appropriate, centers next to them.
So maybe patients come to you at Harvard and Mass Pioneer. You take a sample of their healthy stem cells from the other eye, you grow the stem cell sheet, and then you can transport it to Idaho or Florida or Arkansas or wherever it's needed.
I think so. I mean, we have a lot of experience in transporting corneas. So with this wonderful transport system that we have used for CALIC, I think it can be really transported to other states.
Sounds great. Now, outside of this specific study, what other areas of ophthalmology or regenerative medicine excite you right now, and where do you see the field heading in the next 5 to 10 years?
Well, I'm very excited about being part of this regeneration of cornea wave. Cornea is made out of several layers. So this is first layer, the critical layer of epithelium. But then there's also the inner layer of the cornea called corneal endothelial cells. And those cells are a little bit different. They are not intrinsically dividing in the body. They're kind of, you're born with a certain number of these endothelial cells. You gradually lose them with age. And then in certain diseases, you lose them faster. So there's also now a goal to regenerate those cells with cell therapy. And I think there are lots of programs that are addressing that. And I'm really excited about that kind of layer by layer restoration of cornea goal.
Yeah, that's amazing. Eventually, maybe we'll be able to just inject some endothelial cells into the anterior chamber and they'll just attach to the back of the cornea. We won't have to do DMEC or DSEC corneal transplants anymore, right?
Exactly. So that is where we're heading. And, DMEC or DSEC, they work very well, but you are dependent on a donor. And a lot of times you don't have a very quantitative assay to assess how good are those cells are. You just look at them and, think that they're okay. But with this cell injection therapy or uh, any kind of cell therapy, you have a little bit more control of what you're giving to a patient. And of course, less invasive potentially in the way we are inserting them.
Now, developing this new treatment protocol that you've done is extremely complex, time consuming, very expensive. What were some of the biggest hurdles you had in this project, and how did you and your team overcome them?
I think the biggest hurdle was to really develop the process and how to assay those cells without destroying the final product.
Hmm.
Because even when you do, let's say a bone marrow transplant or even endothelial cell injection therapy, you have a lot of cells and you can just take a little piece and test those cells that you're going to be injecting. But here with CALIC, you couldn't. So I think that was the major, I think, innovation for us is to develop the two-step process. I think, also enrolling the patients, developing clinical endpoints, that was not really clearly defined, and we had to think quite as a team. Again, I worked a lot with my collaborator Reza Dana and Jia Yin, other cornea surgeons in the Mass Eye service to really develop clinical endpoints.
Now, you're also an educator and you're training future ophthalmologists, residents, and fellows. What advice would you give young researchers or clinicians or surgeons who want to make a meaningful impact in medicine in the future?
I think the biggest thing I would say is to follow your passion. So if you have something that is just really in your mind and you really want to do it, you just have to do it and you have to persist on it. I have to say that, it took us so many years to develop this technology, and there were times where I felt that maybe it's not going to work, but just persisting on it, it definitely pays off. I think that would be my main advice, persistence.
Right. You have to keep going at it. At times you get results that make you depressed and make you think that it's not going to work. But if you keep working on it and you enjoy what you're doing, often you get good results, as you've proven, right?
That's correct.
You have to be optimistic, not pessimistic as well. Now, how do you stay recharged? And are there any personal interests or hobbies that influence your professional activity and keep you going doing all these things?
Well, I think that, I would say my biggest support system is my family, and I'm very lucky to have a very supportive family who understands that I might not be home for dinner and I might be working on the weekend, and I'm very grateful to them. I think on a hobby side, I really take great pleasure in gardening and growing flowers. I don't necessarily like gardening for vegetables, but I want flowers because flowers are beautiful and they always make me so happy.
It's great. Now, if you could fast forward 10, 20 years from now, what do you see as the impact of your work? And what's the one thing you hope to hear people say about your contributions and accomplishments in ophthalmology and patient care in the future?
Well, I think that the biggest contribution is we developed a technique to perform cell therapy that is FDA compatible, and I think we set the stage for that. And I think many other cell therapies that will be coming either for epithelium, for endothelium, for retina will be potentially looking at the platform that we have developed to see if, that is the way to accomplish safety, feasibility, and show the potency of a cell therapy product. So I think that that's a good first step, but I have no doubt that it will be much, much improved in 10 years, and there will be many other innovations that make this even more streamlined and hopefully cheaper and hopefully much more, quicker to do.
Also be great if in 5 or 10 years, corneal surgeons around the world doing the Urkunis procedure to save their patients' vision and corneas. That would be awesome, right?
I really, really hope so because we have so many patients who are asking for it right now and who need it. And we need to really develop it further for that accessibility to everyone who needs it.
Now, all the doctors I've been interviewing, I've been asking them about AI because AI is one of the hottest topics in addition to stem cells. So where do you think AI is headed in ophthalmology in the next 5 or 10 years? Can you predict? Are all ophthalmologists going to be out of work and robots with AI are going to be taking care of patients? Or is that just science fiction?
I think AI has a huge role in general ophthalmology, but I want to kind of comment on where I see AI going specifically for the interests that I have. And I think that we still need to understand a little bit better how the stem cells function and whether people have stem cells when it seems like they don't have them, but maybe there's still some residual stem cells. So I see AI really helping us with imaging of the cornea and kind of predicting maybe the outcomes of stem cell therapy or any cell therapy, because the AI might kind of synthesize a much larger set of data that we're now unable to kind of predict with just by looking at a patient. So I think in cell therapy, it has a huge potential. For example, AI used in imaging of cells as they're growing in culture. That would be wonderful because if we could maybe pre-select more stem-like cells in culture, that would improve those grafts, that improve the efficacy of those transplants.
Wow, that's a great idea. Get AI to image all these cells, and after it images enough of them, it can tell you these cells look great, but the other ones don't, and help you select healthier and better cells.
I think that's a really the future.
So this has been extremely informative and educational for me, and I'm sure the public out there as well will enjoy it. I want to thank you again for taking time from your busy day and schedule and research and teaching and doing surgery to join us today and explain this very procedure.
Thank you so much, Robert.